Hello, my name is Tom Stinchcombe. I work at Duke Cancer Institute in Durham, North Carolina. I'm a thoracic oncologist who specializes in clinical care as well as clinical trials for patients with thoracic malignancies. So recently, the FDA approved adjuvant osimertinib for patients resected non-small cell lung cancer, stage 1B through 3. I think that and this is for patients with a known EGFR mutation. I think there have been a lot of interest in adjuvant EGFR-directed therapy, tyrosine kinase therapy. Some of the previous studies had used first-generation therapies or were very small or single-arm phase 2s. And this was a large phase 3 trial, global phase 3 trial, and took patients who had undergone resection and randomized them either to osimertinib or placebo. And I think importantly, these patients had a confirmed and known EGFR mutation. What the trial found was that the adjuvant osimertinib delayed recurrence, or what we refer to as disease-free survival. And so it prevented the recurrence fairly dramatically at this point. And I think this has been a very controversial trial within the Thoracic Oncology Committee. You can Google and get a number of different editorial points of views on this. And I think the reason why it's been controversial is in the adjuvant saying we've generally used overall survival to really prove that we are impacting and curing patients at a higher rate. The trial left open the question, well, maybe the people on the placebo arm will get osimertinib at the time of disease recurrence and have a very similar survival. And more importantly, a proportion of them won't need adjuvant osimertinib. Now, those are very important questions, I think, when we really talk to patients and as a field. I think the challenge is that the drug is now available and we have to have this conversation with the patients. And it's been, frankly, a little bit of a difficult conversation because we do have patients that are EGFR mutation, and I think most of the time when the patient perception is when they hear this, they say, yeah, I'll take it and it will prevent the disease from recurring. And the ambiguity around the overall survival benefits is a little bit harder to communicate because what patient wouldn't want to prevent the cancer from coming back? It's a very intuitive desire to do this. And so I think this is one of the challenges that we faced. And then you have to be on the pill for 3 years. And I think that this is a little bit different for lung cancer doctors because historically when patients had metastatic disease and were on osimertinib, they had a high symptom burden. They started osimertinib, the symptoms went away. The side effects seemed really minor in comparison to the disease-related symptoms. But in this case, there's a little bit of concern that if you're on it for 3 years, this sort of low-grade rash and GI toxicity and diarrhea and other things may impact your quality of life. And so I think those are some of the questions that come on. Now, I think the other question in terms of how we approach patients is molecular testing. This has been standard for metastatic patients, but until this trial, there's really no reason to test patients in the adjuvant setting outside of intellectual curiosity, because it didn't really change your management. Now, with this change, I think we're doing more and more molecular testing in early stage patients. And I think there's a debate of whether should you do a big panel test of either 50 to 250 genes under the premise that the time and effort to do tests for one gene is very similar to tests for multiple genes. And so you might as well look at them all. And you'd get the EGFR test, and then you'd get some additional molecular alterations that may be helpful if the patient does reoccur or may help you in the future. Other people have argued that you just should do the single EGFR mutation test, single gene testing, because there's only really one therapeutic option out there, and you should just really sort of focus on the one therapeutic option. And the detection of these other mutations is just noise. It's not going to be really helpful to the patient or to you as a clinician in deciding the next step of therapy. And so this has created a debate. And obviously, I think underlying some of this debate is the reimbursement. Are they going to reimburse for the single gene test, or will they reimburse for broad panel testing? I've adopted the broad testing panel. And I think the reason behind this is I think the more information you know, the better it is and the more helpful it is for the patient. For instance, I had a patient who had a surgical resection, stage 3A disease, getting adjuvant chemotherapy. I did the testing and she had an ALK rearrangement. I wouldn't use an ALK inhibitor in the adjuvant setting outside of a clinical trial at this point. But I did go in and tell the patient as well as the husband that, hey, if this does come back, we do have a good option for you. It's a non-chemotherapy option. And I think there's value in having those conversations, especially for our patients with stage 3A disease, where there's a very high rate of potential relapse. And so I think that's important. I think the other thing that is, we're a referral center, so many patients will come get their surgery, see me one time, then go back to the community. And I like the idea of doing the testing so that 2 or 3 years if that patient does relapse, all the pertinent information is available to that referring oncologist, and they can just implement the therapy, or they have a little bit more knowledge about it. But these are my personal opinions and maybe unique to my practice. I think this is going to be a big discussion within the field, how much testing is really justifiable for our resected patients.